Amos Onegi, with Dr. Amos Onegi, the senior pharmacist of MULAGO National Referral Hospital. Thank you so much for your time, sir. Before we proceed, I would like to ask everyone if you can see my screen.
Yes, we can.
Okay. Then we can proceed. Dr. Amos, the floor is yours. Thank you.
Okay. All right. Thank you, Mutesi. Good evening, everyone.
Good evening, doctor.
Good. Today, I think we shall not take a lot of time. TB is a small component of infectious diseases. So let's give it about 30 minutes to 1 hour. We can be done. So let's go to the slides and start. So basically, TB is a chronic infection caused by Mycobacterium tuberculosis complex. We have about 5 species. There's actually one that I omitted here. You can add it. We have Mycobacterium tuberculosis itself, the commonest. And then we have Mycobacterium bovis, the one that you can. We have Mycobacterium avium, africanum.
Maria Esther, please mute your mic.
And lepri, the one that causes leprosy. I didn't put it in the slides, but you should have it that the causative microorganism for leprosy and TB are the same. And that's why even in the pharmacotherapy, you will see the drugs used in leprosy treatment are the same as the drugs used in the other TB treatment. So transmission is through air droplets when you cough, and the droplets that you release in the air can be inhaled by, and then your immune system, the macrophages, come around it and encase it, and then they form like small circles within your lungs. And that's usually what is visualized in the X-rays. Okay? It can be there dormant in your lungs, depending on your level of immunity and the level of bacteremia. If the bacteremia is high, you come up with the TB disease. If it is low and the immunity is good, you can have a dormant TB. Okay? That's basic. Someone should unmute that. So that's basically the introductory bit. The clinical presentation of TB. TB will present with high-grade fevers, especially in the evenings, weight loss and loss of appetite, excessive night sweat, chronic cough for more than 2 weeks, chest pain, and purulent sputum. So those should be your warning signs as you're at your pharmacy counter. There's papiers, there's Catherine, you mute your. Okay, let's go on. So those are the clinical presentations. So as you're at your counter dispensing, you should be very careful with people who come coughing and having weight losses, complaining of sweating, they're losing weight, their appetite is poor, don't just treat them as ordinary cough. Should quickly refer them for further investigations. You should always have suspicion of TB at the back of your mind as you dispense cough medicines to patients in your different respective pharmacies. I have a story of a client of mine whom actually we kept treating, okay, it's way back, whom we kept treating for so long, changing different antibiotics, thinking it is just normal cough. And it turned out that she actually had MDR TB when she went for gene expert. So let's not keep picking money from these people just because we want to improve our sales at the pharmacies. Okay. All right. So classification of TB infection can be, there are many ways to categorize or classify, but I've chosen the two most important classifications for our setting, depending on the anatomical site which is affected. Okay, Mutesi, keep controlling your people. Okay, so depending on anatomical sites, we can have pulmonary TB, okay? Or we can have extrapulmonary TB. So extrapulmonary TB can affect the bones, the meninges, the skin, the pericardium. All those are sites of TB infections. So when we go into the treatment, we shall see that pulmonary TB and extrapulmonary TB are treated differently. So we should be aware of that. Also, depending on resistance to the TB medicines, we could have drug-susceptible TB or drug-resistant TB. So drug-susceptible TB mainly are TB that are sensitive to the first-line medicines. The first-line medicines are mainly four. We have rifampicin. We have rifampicin, we have isoniazid, we have ethambutol, we have pyrazinamide. Those are the first-line medicine. But what we consider to be drug-sensitive TB is mainly sensitivity to rifampicin and isoniazid. Those are the two drugs that we consider. And then drug-resistant TB. We can have resistance to rifampicin, isoniazid. We can have resistance to resistance to fluoroquinolones, resistance to bedaquiline, resistance to linezolid. We shall look at that in detail, the drug-resistant TB, and how we again sub-classify them. We have a pre-XDR, we have, we have MDR first, pre-XDR, and XDR. Okay?
Need a book for this.
Okay, let's move to the diagnosis. So the diagnosis of TB is mainly we can do sputum smear, that is a microscopy. I hope all of you in your microbiology came across acid-fast bacilli staining. Mutesi, you know that?
Yes, sir, we did.
Yes. So that is one diagnostic method. So it's basically a staining method, and then you view under the microscope. And then we can also do culture. Now, the culture is mostly used for for monitoring purposes. And also in diagnosis, it also helps in looking at the level of bacteremia, okay? High growth, minimal growth, okay? So it's good for monitoring. So routinely, the patients are requested as they are on treatment to submit samples for culture. So it's one way of monitoring their prognosis. And then the gold standard for diagnosis of TB is the gene expert. This is a molecular test that looks at the DNA of the mycobacterium. So now gene expert is the gold standard. It's basically every patient should be a gene expert, and it also detects rifampicin resistance. So it will tell us whether this patient is having a drug-susceptible TB or a drug-resistant TB. So if you have a drug-susceptible TB, you go to first-line treatment. If you have a drug-resistant TB, you go to... You're not hearing me? Are you hearing me?
Yes, yes, doctor, you are clear.
I'm clear. Okay, fine. Yes, so if you have drug resistance TB, you go to the second line treatment. And then another diagnostic method used is the TB LAM. This is used for HIV positive patients, TB HIV patients, okay? So here they use the urine of the patients to make the diagnosis. There's a strip that usually is used to do that. And then it's also a molecular test, okay? Just like the gene expert. And then we have the X-ray. Now the X-ray is actually one of the major diagnostic tools. The X-ray usually will tell us the extent of the disease and the lung damages, and it will help in grading the disease as severe or non-severe. Because these other molecular tests may not tell you that the disease is severe or non-severe. Okay? Yeah, Mutesi, let's go to the next slide. So yeah, let's continue with the classification. So now this is an extract from the Ministry of Health guideline, the NTLP. NTLP is National TB and Leprosy Program. So you can see drug-susceptible TB is TB that is not resistant to rifampicin and isoniazid, okay? And then MDR TB is TB that is resistant to rifampicin and isoniazid. That is MDR, multi-drug resistant TB. And then pre-XDR, in addition to resistance to rifampicin and isoniazid, there is also resistance to a fluoroquinolone. Now, from MDR up to XDR, all these are called drug-resistant TB, okay? Now, the types of drug-resistant TBs can be MDR, where there's only resistance to rifampicin and isoniazid. It can be also pre-XDR, where there's resistance to rifampicin, isoniazid, and a fluoroquinolone. We shall come to the drugs. One of the main fluoroquinolones that is used in TB treatment is levofloxacin and moxifloxacin. I strongly encourage you people to safeguard those molecules and not use them for other conditions, because they are our second line drugs actually in TB treatment. And then XDR TB, that is extensively drug-resistant TB. In addition to resistance to rifampicin, isoniazid, a fluoroquinolone, there's also resistance to one of the main drugs called bedaquiline or linezolid. So you can see in XDR, we're having resistance to 1, 2, 3, 4 drugs. It can even go up to 5 drugs. This is a very deadly TB. The prognosis is very bad. When you contract this kind of TB, the chances are high that you will die. In the whole country, we can sometimes have like 1 or 2 patients. These cases of pre-XDR can be many because of a lot of community exposure to these fluoroquinolones. We can have cases of pre-XDR. MDR is very common because of poor adherence and other factors, patient factors. Okay. So I already mentioned some of the drugs, but I want us to look at these drugs that are used for treating second line, the drug-resistant TB. Okay. The drug susceptible TB has 4 drugs. I told you already. We have rifampicin, isoniazid, ethambutol, and pyrazinamide. Now, the drug-resistant TB has these so many drugs you see here. They are grouped into Group A, Group B, and Group C, depending on their level of importance and potency. Okay. So we have in this Group A, we have levofloxacin as one of the mainstay drugs. We have a drug called moxifloxacin, which is also fluoroquinolone. It's also one of the mainstay drugs. You either use levofloxacin or moxifloxacin, but you don't use them together. We have a drug called bedaquiline. I don't know how many of you met bedaquiline in your pharmacology books, but it's the mainstay drug in second-line treatment. And then we have this drug called linezolid. I'm sure many of you have met linezolid in your pharmacology books. I think it inhibits a protein synthesis somewhere. Somebody will remind me on the mechanism of action, but I know it inhibits protein synthesis. Okay. We have in Group B, cycloserine. We have also clofazimine. Those are the main 2 drugs in this Group B. In Group C, we have ethambutol, we have delamanid, we have pyrazinamide as the main drugs, but we can also add these imipenems, meropenems, amikacin. Although we have moved away now from these injectables, the amikacin, the streptomycins, PAS, all these now are no longer available for our Ugandan setting, but we have left them there in the as Group C drugs. So now when you're doing regimen construction, precedence is given to Group A drugs, followed by Group B drugs, and then the Group C drugs come when there are usually issues with any of the Group A or Group B drugs. I must tell you that TB patients take a lot of drugs. One patient can be on 5 different antibiotics. One patient can be on 5 different antibiotics, and each antibiotic is taking about like 3 to 4 tablets. So one patient can be taking like 15 to 16 pills per swallowing. That's quite huge. So there's a big challenge with adherence because of the pill burden. So you can see down here, factors leading to drug resistance, patient-related factors, adherence is a big challenge. Most of these patients are very poor. They don't have good food. That also contributes. They don't even have caretakers. So all these are issues that can lead to abandoning treatment and then resistance. Provider-related factors. Sometimes we run out of stock with the drugs. And so that's not a patient factor. You, the provider, you're the one letting down the patient. The healthcare system, diagnostics are a challenge still. So all these can contribute. So let's go to the management of the TB disease. Drug susceptible TB. DS is drug susceptible. Somebody remind me what a drug susceptible TB is. Let us see if we are following me. What is drug susceptible?
Maybe I could help.
Yeah, you help me.
Which is sensitive to rifampicin and isoniazid.
Correct. So you can see the treatment for it is 2 months of rifampicin. You must know these abbreviations, okay? Let them not look strange to you. The R is rifampicin, the H is isoniazid, the Z is pyrazinamide, the E is ethambutol. So 2 months of these 4 drugs, it usually comes as a fixed dose combination. So all the 4 are in one pill. And then you continue for 4 months with rifampicin and isoniazid. Again, also this comes as a fixed dose pill. So that is in adults. Then in children, when we shall come to side effects, we shall realize that children don't tolerate ethambutol very well. So usually children are managed with rifampicin, isoniazid, and pyrazinamide, plus or minus ethambutol. So their fixed dose drug is usually this RHZ. The ethambutol comes as a single separate molecule, not qualifying, depending on the age. Somebody remind us the side effect of ethambutol to children. I'm sure you know that. Who's giving us an answer, please? Side effect of ethambutol, particularly in children. Number of you have rotated in TB ward already. Is Jolly in? Okay, basically, ethambutol's major issue is optic nerve damage and, of course, the color blindness in children. So we try to avoid it in children, except the older children who can tolerate is where it can be used. So it's a plus or minus when it comes to children. And then there are incidences where you can have resistance to isoniazid alone, monoresistance, without resistance to rifampicin. So you there don't qualify to be grouped as a drug-resistant patient. But when you have resistance, rifampicin monoresistance is usually straight away taken to be a DRR patient is straight away taken to be a drug-resistant patient. In most cases, rifampicin resistance goes hand in hand with isoniazid resistance. But there are cases where there's only isoniazid resistance. So in such cases, you still give the rifampicin because these drugs now come as a fixed dose pill. It's usually hard to remove this H out of it, yet already the patient is resisting it. So in this case now, we do the 6 months of all the 4 combinations in addition to levofloxacin. I hope this point is clear, because somebody is going to ask me, if there's isoniazid monoresistance, why are we again still having isoniazid in the treatment? Just because these pills come as fixed dose, like all the 4 combinations in one. So there's no way we can remove it. But ideally, the isoniazid in this case is now playing no role, okay? So what we add is the levofloxacin to back it up. So up there was drug susceptible TB. Now let's go to latent TB treatment. Okay, that's the yeah, that's where it's okay. That's the place. Be there. So latent TB, just as I told you, the pathophysiology of TB is that it's a slow multiplying bacteria. Okay, so when it usually lands in the alveoli, in most cases, your body defense system, the macrophages, engulf it and keep it dormant until only when your immunity is compromised. That's when it can become a full-blown disease. So majority of us healthcare workers and patient care takers are actually having dormant TB. Some preventive treatment. Health workers need this preventive treatment. Patient caretakers need this preventive treatment. HIV patients need this preventive treatment because anytime they can get full-blown disease if their immunities are compromised. So we basically have 3 drugs that can be used to eradicate this dormant TB from our alveoli. We have isoniazid in combination with rifampicin. Now, the P is rifampicin, the H is isoniazid, the 3 is the duration for which you take it. So this is a 3-month preventive treatment. Okay? You will see this abbreviation TPT. TPT is TB preventive treatment, or you will see IPT. That's an old one because previously we were using isoniazid. So IPT was isoniazid preventive therapy. But now we are having 3HP has come on board. So we commonly now use TPT. In children, they use rifampicin and isoniazid for prophylaxis. They do not use 3HP. So rifampicin used in children is still not well researched. This 6H is the older version of TPT, where we would give isoniazid for 6 months, okay, 300 milligrams. So those are the different drugs used to eradicate latent TB, okay? So you should also under diagnosis, latent TB usually, the commonest diagnosis for it is what? Who remembers? The Mantoux test? The Mantoux, the skin test, where they inject the antigen, because already if you have the latent TB and then you have antibodies, so the antibodies will react to the antigen, and you get some sort of a hive on the skin, and they measure that diameter. So that is the commonest test for the latent TB. Let us go to the next. We are done with that. Latent TB. Next slide. So yeah, let's go to DRTB. DRTB is drug-resistant TB treatment. Now, last year, the guideline for treating drug-resistant TB changed.
Maybe a question before you proceed.
Yes.
Sorry to take you back, Doctor. I wanted to ask happens due to the bacteria which has been engulfed by the macrophages sitting dormant with the alveolus for some time, waiting for just immunity to go down. My question is, what is unique about this bacteria that, upon being engulfed, cannot be digested but remain viable, like alive, until maybe the right time comes, then wakes up?
What is unique about it? So the macrophages form like a shield. It's highly mucoid, and so like it remains there, surviving within the macrophages, and it doesn't die. So I don't know. It's a slow replicating bacteria. So once it is engulfed there, it's not multiplying. Okay. I don't know what more you want me to explain, but that's the pathophysiology. Just go look at the pathophysiology of mycobacterium. Actually, you should even look at the cell wall structure. I didn't want to go into those details. When you look at the cell wall structure and all that, it has a lot of protectives. Should we proceed?
Yes, please.
Okay. So last year, the treatment guideline changed. A new drug came on board. Or maybe I first, Mutesi, let's go to the slide before this. Okay, the slide after this, the downer one. I want to start from the old regimen, then I come back to. Go to the next. No. Go back. Sorry. Go back. Okay, basically, I'll go to slide 10. Okay. So the old regimen, I hope we still all remember the drugs I mentioned in Group A, Group B, Group C.
Yes.
If we all remember them, now that's where the old regiment was constructed from. We had 4 different regiments. One regiment is called the Modified Short Treatment Regiment, the MSTR. This regiment was an all-oral treatment. Forget about those stories that you had long time that TB is treated with injections. Actually, you should erase those injections in your mind now. The streptomycins, the kanamycins, and the micacins should not be lingering in your head now. We have moved to all oral treatment, 9 to 11 months. Now, this first regimen, the MSTR, has bedaquiline as the mainstay. You use levofloxacin, you use linezolid, you use the prognosis. I told you, as you on treatment, you're constantly going to be giving sputum for culture and sensitivity until you culture convert, until they no longer see any growth from your sputum. That's when you'll be declared to have healed. Okay? So, this bedaquiline is, the bedaquiline-based regimen is highly effective, and it changed the treatment duration to 9 to 11 months. But previously, these patients were getting treatment for 18 to 20 months. That was a very long duration, and of which 6 months were injections. Okay? Where they keep alternating the other side. The next time they go to your thighs. And remember, these are already emaciated people. And with a lot of side effects of these, they moved to these 9 to 11 months, which was very good. The outcomes are okay. But there were a group of patients who would not qualify. So those who had extensive disease, had comorbidities, are kept on the same drugs up here, but 18 to 20 months. And that was okay for them. Then there's a group that also would not tolerate some of the drugs, the mainstay drugs, the 5 drugs I've highlighted up there. Probably somebody is reacting to levo, somebody is reacting to bedaquiline, somebody is not tolerating linezolid. So one of those drugs can be substituted, removed. Now that forms the third regimen called the individualized. Now in this case, you're going with individual requirement of the patient, okay? And in this case also now you treat the patient for 18 to 20 months. That's individualized. And then the fourth regimen is the salvage therapy. Are limited. There's a lot of resistance. Patient is not tolerating so many drugs. You basically construct a regimen that is available. This is where now you pick a lot of those drugs that appeared in the group C. Any of those can be picked and used as a regimen here. So now if this is fine, let's go to now slide 9. And now we see now the newest treatment for DRR, the new kid on the block. Go to slide 9. So now last year, WHO again, actually WHO guideline came before last year, but in Uganda, as usual, we delayed to change our treatment guideline to this. But eventually last year, the new treatment guideline was rolled out. In many cases, by the way, with the TB, we basically adapt what adapting is we try to tailor what WHO has to our setting, but we do not take it in its entirety, okay? Because of our own challenges here and there. But there are countries that take entirely what WHO has guided. So TB is a public health disease, so WHO has a lot of influence and research that it does on it. So last year we rolled out 6-month treatment. Now we are moving from 9 to 11 months to 6 months. Now the new kid on the block that came is this drug which you're seeing labeled PA. You zoom that thing very well for yourself. So the 6-month has a drug. Actually, most of the drugs are still the old drugs that we have talked about. The B is bedaquiline. The PA is pretomanid. That is the new drug. The L is linezolid. The M is moxifloxacin. The option is that if you don't have moxifloxacin, you can still do bedaquiline, pretomanid, and linezolid, 3 drugs that you do for 6 months. There's eligibility for this 6-month regimen. Now, there are people who may not qualify for it. Now, if you have a fluoroquinolone resistance, the moxi, definitely you will not respond to it. So you can do the 3 drugs, the bedaquiline, pretomanid, and linezolid. So you either have B-palm or B-pal. Hope you're seeing that difference. So it's either B-palm or B-pal. Pretomanid has not been researched very well in pregnant women and children. So those below 14 and those who are breastfeeding and are pregnant should not take pretomanid-based combination. And therefore, for them, they can benefit from the second category here. The next 6 months, do you see this? There's no pretomanid in that regimen. It has bedaquiline. It has another new drug which came also around 2019 called delamanid. It has levofloxacin, and it has cycloserine. So for those who are pregnant, those who are below 14, those who are breastfeeding, that's the regimen they use. And then all is not always, things don't occur always in the normal way. Now, while we want to move everybody to 6 months, there are those who do not qualify for 6 months. Number 1 is the group with the fluoroquinolone resistance. We prefer that they go for 9 months, but a regimen without fluoroquinolone. And then patients who are severely sick, you don't want to also risk them on only just 6 months. So we prefer they go for 9 months. People with comorbidities, HIV patients, diabetic, cancer patients, those category, you'd want them to go for 9 months, okay? And so their regimens are also many, the options are many. So they can go with the bedaquiline, they can go with linezolid, they can go with the moxifloxacin, they can go with the pyrazinamide, all those groups. Generally, all those who cannot, we don't want to risk them on only 6 months. We have left them on this regimen, the 9 months. And those are the drugs that can be used. And then there are still also those who may have to go for 18 months, okay? There are those who have failed on those shorter treatment regimens. You still take them for 18 months. On the regimens that I told you earlier on, the longer regimens, okay? They have failed those shorter regimens. So you need to look at these eligibilities critically. Let's move on. Read this, internalize it. It's a guideline from WHO. But know that there's a new drug, pretomanid. is the one that is causing us to shorten the treatment duration. It's highly effective, and it has been used in other countries already. So the treatment durations have reduced to 6 months because of predominant. But where you cannot use predominant, then you go for 9 months. And those are the drugs you can use. We go to slide 11. So slide 11 is basically a continuation of slide 9. It's still telling us the inclusion and exclusion criteria for the different regimens. The 6 months, yes, you must be an MDR patient. If you are pre-XDR, I told you pre-XDR, you have resistance to fluoroquinolone. So if you are a pre-XDR, you're using B-PAL. You're not having the M in your regimen, okay? If you're an XDR patient, the extensively resistant patient, we are not risking you on 6 months, so you don't qualify for 6 months. You're going for the long 18 months of those other drugs that are in that slide 9. So basically, this is the exclusion and inclusion criteria for the different regimens. I think you should just look at them and take them how they appear here. So inclusion, exclusion is basically on resistance, severity of disease, age category, pregnancy status. Okay. Slide 12 is still a continuation of inclusion and exclusion for B-PALM regimen. So it's the same repetition, but just pick the points there. I want us to look at drug-drug interactions. That's usually very important. That's slide 13. When you're at TB pharmacy, you must know these drug-drug interactions always at the back of your mind. Patients who are on rifampicin-based regimen and at the same time taking ARVs, especially DTG-based combination, there's usually an interaction. Rifampicin is a CYP3A4 inducer. So it's going to lower the plasma levels of DTG. So what usually they do is to double DTG dose. So patient will take the TLD in the morning and then an additional DTG in the evening. You must know those reasons. These are very highly examinogenic, just in case they want to examine TB. Okay, why we double DTG dosage in patients who are taking rifampicin. Bedaquiline and protease inhibitors. So protease inhibitors are CYP3A inhibitors. Okay. So we would not want these to be used. We change to DTG. So what will happen if the protease is inhibiting CYP? It means you will have less metabolism of bedaquiline. Bedaquiline is highly toxic as far as, although it is a very important drug in our treatment, it is also toxic. We shall come to that when we're looking at the side effects of these drugs. So when you're having an inhibitor here, it means you're going to end up with a lot of side effects of bedaquiline because it's not being metabolized. So one of its major side effects is usually
There are few, you don't do internship. By the time you complete like 2 years.
I know who is that. So yes, so we do not want these PIs to cause to make BDQ too toxic to the patients, so we change them to DTG-based regimen. And then also bedaquiline and pretormanid can interact with efavirenz. So in this case, again, efavirenz now is an inducer of the CYP. Now, when it is an inducer, it means also now BDQ and pretormanid will be metabolized faster or more, and then lowering their plasma levels. Now, that will cause us to have suboptimal levels of the drugs, and that is not good. So it means we're not going to achieve our treatment target. So anybody who is still using a efavirenz-based combination should also be changed to DTG-based combinations. Yeah, so those are the major drug-drug interactions that happen with the TB drugs. You should take note of them. Okay, let's go to pharmacovigilance. It's very important when you're TB to monitor for adverse drug reactions. Most of the drugs are toxic. Most of the drugs have only passed just phase 2 of clinical trials, and they are pushed for use straight. Most of the TB drugs actually, they don't go through the phase 3. Straight away they are put into use when they find them to be very effective. They did that with bedaquiline. They've done that with pretormanid. So you need to have to continuously do your surveillance and reporting. I expect you guys to actually be reporting a lot to ND about TB drugs in your respective places of deployment. So these are some of the selected adverse events with the drugs. This LZD is linezolid. It's one of the main drugs in TB management, and it causes bone marrow suppression, resulting into anemia and all other blood-related disorders. This is one of its commonest side effects. Another commonest side effect of linezolid is ototoxicity, very common, and also skin reactions can happen with it. There are also drugs that cause peripheral neuropathy. Even linezolid is still a culprit. Pretormanid is a major culprit. Some of the fluoroquinolones are also causing peripheral neuropathy. Optic nerve neuritis, linezolid is still a major culprit. Pretormanid is a major culprit. So now in this case, if somebody is presenting with this anemia, optic nerve neuritis, you should have it at the back of your mind that most likely this drug is the one responsible for that. And so you look at what the patient is taking, and then you go and pick your NDA reporting forms or the apps that you have on your phone. You report, list the drugs the patient is taking, and then causality assessment can be done to find the offending drug. Where your suspicion is good, the offending drug can be stopped or substituted accordingly. Yeah, fluoroquinolones have a bit of, they can easily cause psychosis and anxiety and depression. Should have that. Insomnia is very common with pretormanid and a bit of also BDQ. Though BDQ, the main side effect is QTC wave prolongation. That's its major side effect. And it's the main reason why all patients, before initiating them on bedaquiline, they have to do ECG and echo. All patients, before initiating them on linezolid, they have to do CBC to assess for their HB levels. Anybody who is anemic should not be put on linezolid. Anybody who has already heart problems should not be put on bedaquiline. Seizures, tremors, common with fluoroquinolones and linezolid. Why I'm focusing on this, these are the things that will always be reported to you as the pharmacist. So you need to pay keen attention to them. And you must have them always at the back of your mind. Pharmacovigilance is a core JD for a pharmacist, job description of a pharmacist. So you should know the side effects of some of these drugs. Nausea, vomiting, diarrhea, a bit common with maybe pretomamine and linezolid and bedaquiline. But you see, nausea, vomiting can happen with any drug anyway. But yeah, those are some of the drugs. Hepatitis, gastritis, abdominal pain, common with all of them anyway. Muscle aches, common with linezolid. Actually, linezolid causes myalgia. It causes lactic acidosis, so it's a common side effect of linezolid. Joint pain, linezolid still. Pruritus, itching, pretomamine can cause that. Rash, linezolid, and all. So yeah. So look at all those and appreciate them. Find time, go to your TB ward for those of you who have TB wards in your hospitals, and orient yourself with these drugs and ask the clinical team about some of these common side effects that they're experiencing on their wards with these drugs, and report them. For them, they see them and don't even bother about reporting them. QTC prolongation, moxifloxacin, bedaquiline are the commonest culprits here. Yeah, those are the major things I think I needed to present for you. I've used 1 hour. Let's take some few questions and Mutesi, you were not moving. Me, I moved a long time and left you behind. Sorry.
Apologies to everyone, but I will share the slide for everyone to have a look and to read further. Thank you so much, Doctor, for the presentation. There are a few questions in the chat.
In the chat, let me see.
Like two.
I'm seeing one. Yes, let me see.
I have one question, Doctor.
Yes, sir.
All right, this is enough Samba Joshua. I just wanted to inquire about levofloxacin because I've so far got one prescription where we had that given the patient levofloxacin with isoniazid, and the complaint was that this patient was reacting on rifampicin, so he was getting serious. He was getting serious itching of the skin and as well as skin rashes all over the body. So they decided to change to isoniazid and levofloxacin. So I wanted some clarity on that.
Yes,
and
that is true. That can be done where patients are reacting to rifampicin, but you want to maintain at least 4 drugs. You see, the treatment, the principle behind TB treatment is about synergy. Okay, different drugs working differently to give a better outcome. So you do not put patients on a few drugs. You try as much as possible to have at least 3 to 4 drugs up to 5 per patient. So yes, if a patient is reacting to rifampicin, it's not that it is resistant to rifampicin, it's just a reaction. So we bring on board the levofloxacin just to add up so that a better outcome can be got here.
Doctor, about the duration of that regimen, just in case it has been chosen.
The duration is still 6 months. Yeah. if it is drug susceptible TB. Mm. Another question? Oh, I respond to these ones which are in the chat. Let me see.
I wanted to raise a question just still connected to that. You said one of the monitoring parameters is actually culture. Now, for example, in the case where you have carried out that treatment regimen for 6 months, but the culture is still showing that the bugs are still there, what do you do?
Now, as long as you're still within the duration of treatment, you first continue. So if you've like because the treatment now, if for treatments that are like 9 months, if within 6 months it's still showing, depending also on the growth, okay, we expect the growth to be reduced, right? Because in culture they count the growth. So if the growth is reducing, you proceed with the treatment until the end and see if it has while of course also there's resistance monitoring. I forgot to say that. Usually resistance monitoring is done where the person is not culture converting easily, then they have to monitor for possible resistance. Have I answered you?
Yes. Yeah, somehow. Thank you.
Okay.
Doctor, I have a question.
Yes.
Yeah, my question is about the TB lab test. In your presentation, you said it is mainly limited to those people with and what could be the reason for that?
I haven't really gone into the biochemistry of it so much, but there's a reason. I need to look up to the biochemistry why it is for only TB HIV patients. We can all look up to that. I will not want to lie to you why it's only for HIV and HIV TB patients, but it's only for them. Let's look up to the biochemistry of that. Why it is for them.
Okay, doctor. Thank you.
Okay. Karen. Another question?
I think you can respond to the ones in the
chat. Okay, so yeah, so I'm saying somebody is saying I think I asked about linezolid. So they're saying linezolid inhibits bacterial protein synthesis by interfering with translation. That's okay. Optical neuritis, common with linezolid. Would you please talk about nucleic acid amplification test NAT under the TB test? Yes, that's a new test. It's true NAT actually, they call it that. Yeah, it's also a new test for diagnostic test for TB. Under TPT, when does one qualify for 12 months therapy? No, there's no 12-month therapy for TPT. How have I answered that? Slides ain't moving. Which category of patients on ART need 3 HP? All patients on ART can take 3 HP. Linezolid seems to have the highest risk among all the drugs. Is there a possibility of the government to bring in another oxazolidine drug? Or like which one? Which other oxazolidine drug is there? So, but much as it has a lot of side effects, but it's a highly potent and very important drug in TB treatment. So it's about risk benefit. And the good thing is in TB, you have to do active drug safety monitoring. So all these patients, when they come, they subject them to monitoring tests. They have to do those optic tests. What is it? The Snellian, the Sierra test. They have to do audiometry for them. They have to do ECG echo for them. They have to do CBC for them. All these tests are done in every visit, so that these adverse drug reactions can be captured as early as possible, and changes can be made in the treatment. Okay, I think I've responded to the questions in the chat.
Thank you so much,
Okay.
Dr.
Karen, thank you, and have a good night.
Thank you so much, and thank you everyone for being part. Bye.